And with that, I do think we will get started. I'm Gerard Silvestri. I'm a pulmonologist at the Medical University of South Carolina here in Charleston. And today I'd really like to thank Lynn Tanoue, who's a professor of medicine and vice chair for clinical affairs and internal medicine. And she's also the director of the lung cancer screening program at Yale School of Medicine. And she's an amazing lecturer and dear friend. And she will be speaking to us tonight about complications of the treatment of lung cancer. One of our panelists also is Ray Osaro-Giaban, who is a multidisciplinary thoracic oncologist and head of that program at the Baptist Cancer Center in Memphis, Tennessee. This program is being sponsored by AstraZeneca in conjunction with CHEST. And I'm going to turn it over now for a didactic session by Lynn, followed by a real fireside chat amongst the three of us regarding the pulmonary complications of lung cancer treatment. Thank you so much, Lynn, for joining us.
Thanks, Gerard. It's a real pleasure to be here with you and Ray to do this webinar. I am going to talk about pulmonary complications of lung cancer treatment. We'll start with a general approach to the lung cancer patient who has suspected treatment-related pulmonary toxicity. I'm going to focus mostly on pulmonary toxicity related to TKIs and to immunotherapy. So we know that 10% of all cancer patients develop treatment-related pulmonary complications, and that patients with lung cancer appear to be at increased risk. And that makes sense because we know that lung cancer patients have a higher likelihood of having underlying lung disease, such as COPD or interstitial lung disease, and so often have decreased baseline pulmonary reserve. We also suspect that background pulmonary injury places them at risk to have further injury related to drugs or other cancer-related complications. We also are very aware that diagnosis of pulmonary toxicity can be hard and can take a long time because the symptoms are so nonspecific. Lots of patients have shortness of breath, cough, or chest discomfort. Similarly, the radiographic findings are typically not pathognomonic. And we also are aware that many cancer patients are immunosuppressed, and those patients have a higher risk of pulmonary infection. And so the diagnosis of drug toxicity is almost always one of exclusion. You have to exclude progression of the underlying cancer, exclude other competing causes of pulmonary decompensation, in particular in the lung cancer population, exacerbation of underlying lung disease. Everybody with cancer is at risk for infection, and now we have to deal with COVID thrown into that mix. And because a lot of lung cancer patients smoked, they are also at higher risk to have cardiac disease, congestive heart failure, and so forth. And again, the lungs are the most common site of infection in all cancer patients, and so that remains on the differential. This is always made more difficult by recognizing that if we decide the patient has drug toxicity, that's going to have consequences in terms of their treatment, particularly if the treatment was of benefit. And so it's important that we do these assessments carefully. We should have a low threshold for aggressive diagnostic evaluation, including invasive procedures when they're indicated. So the first step is typically to assess the likelihood of infection, particularly if the patient is immunosuppressed, neutropenic, on cytotoxic chemotherapy, and so forth. We can use PFTs, particularly the diffusing capacity, with the caveat that many cancer patients have difficulty doing this kind of test, which is very effort dependent, and that there is day-to-day variation, even at the best of times in pulmonary function testing. We rely heavily on imaging studies. They may be our first signal that there is actually a problem and give us a means of monitoring progress or worsening. And that's usually our window into evaluating competing diagnoses like worsening underlying lung disease, cardiac problems, and so forth. And we have an array of diagnostic procedures, starting with bronchoscopy, including transthoracic needle biopsy, and even including surgical lung biopsy when it's necessary. And so while I'm going to focus on TKIs and immunotherapy, I really should stop a minute and talk about pulmonary toxicities related to cytotoxic chemotherapy, since this has really been the mainstay of therapy, particularly for advanced patients, for decades. So most patients with advanced non-small cell lung cancer, the treatment used to always be a platinum-based doublet. Fortunately for those patients, pneumonitis is pretty rare. There's pulmonary toxicities related to platinum is pretty uncommon. That's also the case for drugs like pemetrexed and etoposide, as well as the camptothecins, such as immunotherapy-related, where pulmonary toxicities are fairly uncommon. Gemcitabine, however, can be associated with a non-specific dyspnea syndrome, particularly with infusion in about a quarter of patients. While they rarely get pneumonitis from gemcitabine, radiation recall is well described. Diffuse alveolar damage described but rare. And the risk factors for pneumonitis and radiation recall obviously are prior radiation, but also older age and combination therapy with taxanes or bleomycin. The taxanes are well described to cause pulmonary toxicity, predominantly pneumonitis and hypersensitivity reaction. They too have an increased risk of radiation recall injury, and the predominant risk factor for taxane-associated pneumonitis is underlying interstitial lung disease. And for these chemotherapies, the approach is to withdraw the drug. For severe toxicity, as with all other things, we tend to throw steroids at these people, but there really is a dearth of an evidence base for that, other than our clinical gut instinct that a lot of this is inflammatory and corticosteroids may help. The other major category of drugs that we've been using are the VEGF inhibitors. This includes the monoclonal antibody bevacizumab, and in clinical trials, bevacizumab is well described to be associated with an increased risk of pulmonary hemorrhage, with the risk factors being squamous cell carcinoma, particularly located centrally, and cavitary tumors. Patients who have received radiation to the mediastinum in the context of concurrent chemoradiation or even with palliative radiation are at higher risk of TE fistula. The approach to this is to withdraw the drug and support the patient. There are some TKIs available for VEGF inhibition, including sunitinib and sorafenib. Sunitinib can cause cough and dyspnea in up to 19% of patients. And while pneumonitis with sorafenib is rare, these patients often don't do well, and there's a high case fatality rate. These drugs have not been used in large series of patients, and so the jury is still out as to whether these very prevalent adverse effects will go up or down in prevalence. And so I'm going to use a few cases to illustrate some of these points, and this is the first one. This is a 74-year-old man with background mild COPD and cigarette smoking who was diagnosed with a T1C N2M0 stage 3A adeno of the lung, who was treated with concurrent chemotherapy with carboplatin and paclitaxel and full dose radiation. He tolerated his treatment well. This is his primary site, which you can see was pretty small, but he had a lot of mediastinal involvement. The chest CT that was done at the completion of the chemoradiation showed that the primary site, as well as the mediastinal nodes, had all decreased substantially. I want to point out that this is an older case. In 2021, this patient would have gone on to consolidative immunotherapy with durvalumab, but in this case, several years ago, at the end of chemoradiation, he was thought to have finished his definitive treatment. And I want to walk you through his CT scans. This is at the time before treatment, and it's at the level just below the carina. You can see the subcarinal adenopathy there. When he completed his chemoradiation, this was his completion scan, and you can see that he has developed diffuse interstitial infiltrates that are most obvious in the area where the radiation was given. And the question came up as to whether this was radiation pneumonitis, except that there was really infiltrate everywhere, including more faintly here in the left upper lobe. So all lobes were involved. And so there was great concern that this was Taxol toxicity. This CT is 8 weeks after his chemoradiation. He had severe cough and dyspnea, and he was requiring pretty high flow supplemental oxygen. He had a bronch that showed no infections, and he was started on corticosteroids for presumed taxane toxicity. He continued on steroids for quite a while. He had a very rough course with multiple hospitalizations. He went into heart failure. All sorts of stuff happened. But 8 months after his treatment, he was actually doing better now on a slow taper of corticosteroids. And you can see that the parenchymal infiltrates are improving, but the area that had received the highest radiation dose now was consolidated with air bronchograms. And here he is 2 years after treatment off steroids with no evidence of cancer, doing really well off oxygen. And he actually is now about 4 years out of treatment, doing fine with no evidence of cancer recurrence. And so this case, I think, is a good illustration of a patient who developed drug toxicity from chemotherapy, complicated probably by radiation, but fortunately this case had a very good result. I did also want to introduce you, if you don't already know about this website, pneumatox.com. This has been a kind of a one-man effort by Dr. Philippe Camus in France, and he has maintained this website, which essentially is a compilation of the world's literature on drug-induced respiratory disease over now decades. And the beauty of this site is you can type in any drug, and what will pop up is a listing of the types of pulmonary complications that have been observed. In this case, I put in paclitaxel, and I'm hovering over 1B, which is interstitial parenchymal lung disease. And I think that the real value of this website is not just that it exists and it's really useful, but it actually gives you access to a lot of literature. And while this isn't graded in terms of evidence and quality and all that, it is a wonderful compilation of case reviews to systematic reviews. And you can really easily look at these publication lists. And so if you were interested in paclitaxel-induced pneumonitis in patients with breast cancer, this happens to be a case series and a review. And I have found this site useful actually, particularly in patients where there's a question about drug toxicity and the patient is on a combination of therapies that were never studied together. And so occasionally you can go and find somebody else's case report of that particular situation, and that case may help you understand your own. So pneumatox.com, it's free, it's online, it's a wonderful resource, and I hope that you use it. So moving to targeted therapies, we know now that more than half of all lung adenocarcinomas have a potentially targetable mutation. The most common mutation is in KRAS, but we're very familiar that 15 or more % of all comers will have a targetable EGFR mutation followed by ALK rearrangements, and now a whole host of potentially targetable mutations, for some of which therapies are already available, like EGFR mutations and ALK rearrangements, and for the rest of which some therapies are available, some are emerging, and everything else is in the pipeline. Squamous cell carcinomas have maybe a third of them have a targetable mutation, but we didn't even recognize this 15 years ago. And so this is pretty exciting that there will be targetable mutations for these patients as well. So I wanted to give you a little history of targeted therapies because this field is really only clinically relevant for about 20 years now. Which seems like a lifetime, except that I remember when imatinib came out in 2001. This is Gleevec, and it is the targeted therapy for Philadelphia chromosome positive CML. It was the first TKI used in cancer treatment, and it was like magic that these patients did so well. It totally changed the landscape for patients with CML, and now there's a whole host of TKIs with imatinib as the prototype. All TKIs can cause pulmonary toxicity, and in the case of these BCR-ABL inhibitors, the toxicity is predominantly pleural effusion, interestingly, although pulmonary arterial hypertension has also been described. These drugs are not used for lung cancer, but I just thought that that was an interesting piece of historical data. So let's consider a case. This is a 71-year-old female former smoker who presented with cough and back pain and was found to have an EGFR exon 19 deletion positive lung adenocarcinoma. She had involvement of mediastinal and supraclavicular nodes and multiple liver mets. Her clinical stage was T2A, N3, M1C, stage 4, and her PD-L1 score was less than 1%. She was diagnosed in 2017, and at that time, first line was erlotinib therapy, erlotinib being an EGFR TKI. And she had marked improvement in symptoms and radiographs over the first 3 months of therapy. If this were 2021, this patient would be treated with osimertinib, which is now standard of care for patients with EGFR exon 19 deletion positive adenocarcinoma. 8 months after initiation of treatment, she developed a persistent dry cough. This is her chest CT at that time, which showed no evidence of tumor progression. And in fact, you can see her primary site here, how big it was in the superior segment of the left lower lobe. It had shrunk, and on the CT scan, this was stable compared to the prior imaging studies. So she had all these interstitial infiltrates, and her PFT showed a new restrictive defect with diffusion abnormality. So let's talk about the EGFR inhibitors and their pulmonary toxicity. So the original drug was gefitinib, which was developed in Asia and first used in Japan and approved for clinical use in 2002. And there are now an array of EGFR inhibitors, of which osimertinib is considered the standard of care. Up to 8% of patients develop treatment-limiting toxicities, predominantly in the skin, in the GI tract, and in the lungs. And the most common toxicity is interstitial pneumonitis, which can be seen in up to 4% of patients. Risk factors for development of pulmonary toxicity include Asian descent, older age, male sex, smoking, underlying interstitial lung disease, poor performance status, or combination treatment with checkpoint inhibitor therapy. And it's thought that the mechanism of the injury is because EGFR is important in lung repair. It's upregulated in response to lung injury. And so inhibition of the EGFR signaling pathway may result in impaired repair or regeneration of alveolar epithelial cells. When toxicity occurs, it typically occurs early within the first couple months, which is just about when you're looking for a response. But toxicity can appear after many months of therapy. Symptoms are nonspecific, dry cough and exertional dyspnea. And the treatment for this, the management, is really to discontinue the drug. And if the patient has severe symptoms and hypoxemia, that corticosteroids should be initiated. Interestingly, Asian patients seem to be at higher risk for toxicity. And in the original series published out of Japan, the prevalence of interstitial lung disease in the setting of gefitinib was sometimes in excess of 10%. And originally 2% of cases were turned out to be fatal. However, that kind of severe interstitial disease is fortunately rare in other populations. One important thing to remember is that the TKIs are not immunosuppressing, and so these patients should not be at increased risk of infection related to their cancer therapy. ALK rearrangements are the next most common targetable mutations after EGFR for lung adenocarcinoma, and there are now a number of ALK inhibitors available that are TKIs. These have been predominantly shown to be of benefit in patients with the EML4 ALK fusion oncogene. Like the EGFR inhibitors, when toxicity occurs, it typically occurs reasonably early within several months of initiation of therapy. And these patients too present with pneumonitis as a predominant pattern. One interesting thing is brigatinib, which is one of the newer ALK inhibitors, seems to be able to produce toxicity very rapidly within 1 week, which raises sort of hypersensitivity sorts of questions. But discontinuation of these drugs typically results in resolution, although again, if you have a patient with severe disease, it's very hard to resist the impulse to pull out steroids. There are also clinically available TKIs directed against ROS1, MET, and RET oncogenic mutation. These have their own array of pulmonary toxicities. The ROS1 inhibitors can result in pleural effusion. The MET and RET inhibitors more likely to cause pneumonitis. These percentages of pulmonary toxicity seem really high, and I wonder whether that's related to the fact that relatively fewer patients have these mutations, and therefore relatively fewer patients have been treated. And so again, I think this is an area that's going to develop more over time as more patients are treated with these tyrosine kinase inhibitors. So let's go back to our case. The patient who had been treated with erlotinib for EGFR mutant adenocarcinoma. She underwent bronchoscopy that showed no evidence of infection or cancer. And the conclusion was that she had erlotinib-related pulmonary toxicity with acute interstitial pneumonitis. And remember, this is what her CT scan looked like. So the erlotinib was discontinued and she was started on oral corticosteroids with improvement in her symptoms in the scan and in her pulmonary function testing. 3 months later, the follow-up chest CT showed that the infiltrates had improved, and that's here. You can see the parenchyma was clear. But her primary site, which you'll remember was in the superior segment of the left lobe, actually had gotten bigger again, as had her adenopathy. And it brings home the point that these TKIs don't cure disease, but limit progression. So she was begun on cytotoxic chemotherapy with carboplatin and pemetrexed. Unfortunately, while she initially seemed to respond, she subsequently progressed and presented with brain metastasis that had to be treated with gamma knife. And so at that point, she came back to the multidisciplinary tumor board, which considered that she had progressed on chemotherapy. Her PD-L1 status was known to be negative. And she actually had been a very good responder to erlotinib. And at this point, osimertinib was available, and it seemed there was a high likelihood that this patient had developed a T790 mutation. And after a discussion with the patient, she was begun on osimertinib in January of 2019. But unfortunately, within 6 weeks, she again began experiencing dry cough and worsening dyspnea, and her chest CT at that time showed not just diffuse interstitial infiltrates that had recurred, but these more dense, consolidated, sort of geographically focal areas of abnormality, which were felt to be very suggestive of organizing pneumonia. And so the patient's osimertinib had to be discontinued. So in terms of the tyrosine kinase inhibitors, the take-home points are that they all can cause pulmonary toxicity. Symptoms of toxicity when they occur are nonspecific and can actually mimic cancer progression or exacerbation of the underlying lung disease. When toxicity occurs, it usually manifests radiographically as interstitial pneumonitis, and it typically occurs early, within a few months of therapy initiation, although the time course can also be late. Remember that the TKIs are not immunosuppressing, and while concern for pulmonary infection in a patient with lung cancer must always be present, that risk should not be increased by the use of the TKI. And the management really involves discontinuation of drug and the use of corticosteroids for patients who have more severe syndromes. So I'm going to spend the last minutes of my time talking about pulmonary toxicities related to immunotherapy. So using the immune system to try to treat cancer is a very old concept. There's actually medical literature from like the 1860s where patients were purposefully infected with the concept that this would turn on their body's innate ability to then kill the cancer. And that concept still exists today. For instance, we treat patients with bladder cancer with BCG. And so we know that smoking-related lung cancers are very highly mutated. Those tumor cells are expressing all types of tumor antigens that our immune system, and specifically our T cells, should recognize as foreign, and those cells should be destroyed through immune surveillance. However, tumor cells can evade that immune surveillance by taking advantage of the fact that T cells have both inhibitory and activating pathways. And then specifically for the rest of this talk, the programmed death receptor pathway is one that downregulates T cells. And so if the tumor can stimulate this pathway, the T cells will be downregulated, allowing the tumors then to evade immune surveillance and proliferate. And these inhibitory pathways are called checkpoints. And so if you consider the tumor cell, which is sort of a self cell, it came from us, it's still expressing things like the major histocompatibility complex, which the T cell will recognize as self. And if that tumor cell also is expressing programmed death ligand 1, it can bind to the PD-1 receptor on the T cell, which is an inhibitory pathway and results in this T cell turning off and the tumor escaping immune surveillance. If you consider then that you can disrupt this PD-L1, PD-1 connection, in this case with antibodies directed either against the ligand on the tumor cell or the receptor on the T cell, you can reactivate the T cell, so to speak, by taking away the inhibition induced by this connection. And the T cell then can recognize all those tumor antigens and eliminate the tumor. And this is really the fundamental concept behind immunotherapy. So we have now a wide array of checkpoint inhibitors. The anti-PD-1 receptor antibodies include pembrolizumab, nivolumab, and cemiplimab. And the anti-PD-L1 antibodies include durvalumab, atezolizumab, and avelumab. And if you haven't figured out, all the mAbs are monoclonal antibodies and all the IBs are TKIs. So that it stands to reason, and it was anticipated that these immunotherapies would have immune-mediated adverse effects. And that indeed is what was seen in the clinical trials. And so as opposed to the classical cytotoxic chemotherapy-associated problems with neutropenia and increased infection, the side effects associated with checkpoint inhibitors really are immunologic adverse reactions like thyroiditis, hepatitis, nephritis, pneumonitis, dermatitis. And patients can have a whole array of these. This was a nice review by Remen and colleagues who looked at all the immune-related adverse events with immune checkpoint inhibitors in lung cancer in the phase 3 clinical trials. And what they focused on was the time course. And you can see that most of these immune-mediated adverse events occur early, within weeks to maybe 2 or 3 months of initiation of therapy. And the exception to that is pneumonitis, where the median presentation of an immune-related adverse event or an IRAE is about 7 to 8 months. However, I want you to look at the range of when patients can present with their adverse event, and you can see it goes from 2 weeks to 2 years. And so the bottom line is that as long as the patient is on therapy, they are at risk for immune-mediated pneumonitis from their therapy. And so you just have to continue to stay vigilant. And even if the patient is several years into their therapy, it does not preclude the possibility that the change on their CT scan and the increase in their symptoms is related to a toxicity. So Pillai and al. Did a very useful systematic analysis of the literature looking at adverse events related to PD-1 inhibitors like pembrolizumab and nivolumab, and PD-L1 inhibitors like durvalumab, specifically in patients who had non-small cell lung cancer and were being treated with checkpoint inhibitors. And you can see that the types of adverse events that these patients experience predominantly, again, these immunologic type events, as opposed to the type of adverse effects you would see with cytotoxic therapy. And what came out of this analysis was that the PD-1 inhibitors had an incidence of pneumonitis of about 4% compared to the PD-L1 inhibitors, where it was lower at about 2%. And because this systematic analysis included, over 5,000 patients, that difference, 2% versus 4%, was statistically significant. And so maybe there is a signal here that the PD-L1 inhibitors cause less toxicity. And maybe teleologically that makes sense because the PD-1 antibodies are actually directly interacting with the T cell, whereas the PD-L1 inhibitors are only interacting with the tumor cell. And so maybe you might expect that there'd be less toxicity with those latter drugs. When we see pulmonary IRAEs, they typically are pneumonitis with focal or diffuse inflammation of the lung seen on CT scan. And risk factors that have been identified for the development of these IRAEs are underlying interstitial lung disease, underlying autoimmune disease, although we don't understand a lot about this because typically patients with autoimmune disease were not eligible to participate in the checkpoint inhibitor trials, or prior thoracic irradiation. And there have been efforts to try to describe the radiographic patterns of immune checkpoint inhibitor-related pneumonitis. There are not a lot of series on this. None of them is more than a couple of hundred patients, but there are some patterns that arise as more common, the most common of which is cryptogenic organizing pneumonia-like pneumonitis, where you see these, again, geographically distinct areas of consolidation, atelectasis, infiltrate, that tend predominantly to hug the periphery. The next most common are non-specific interstitial abnormalities that kind of look like NSIP. In this case, there's some interstitial change, and you can see there's some subpleural fibrosis there. Lots of patients show up with ground glass opacities, and these are the classic GGO where you can see through the ground glass and identify the normal pulmonary architecture. These can be very diffuse, as in this case, or more localized. Hypersensitivity patterns are very well described, and the radiographic appearance is the typical hypersensitivity where you see little bitty nodules, maybe in a tree and bud pattern with some interstitial abnormality and septal thickening. And then there's the dreaded pneumonitis not otherwise specified, or any sort of all other comers. In this case, this patient has a combination of ground glass abnormality as well as some peripheral consolidation. But other radiographic patterns are well documented. Some patients will present with, for all the world, what looks like acute interstitial pneumonia or ARDS with severe diffuse infiltrates and profound hypoxemia. And then I did want to mention this, although this is not technically a toxicity, that when we were initially using these checkpoint inhibitors, we were seeing this pattern of pseudoprogression after a treatment was initiated. In this case, this patient had metastases, including this one in the right upper lobe, and started developing these funny little ground glass abnormalities. And within a couple of months, had multiple areas of the lung that looked like this with dense consolidation and some ground glass, which over the next few months seemed to evolve into more ground glass and less consolidation. But behind there, you can see that where that met was the metastasis is actually smaller. So this patient was responding to their therapy, and this was felt to be just a response of the lung around the metastatic sites, and all of this eventually resolved. And lastly, these patients too can experience radiation recall phenomenon. So this is the last case. This is a 52-year-old man who was diagnosed in 2014 with T1C N2-M1B stage 4 adenocarcinoma in involvement of the right upper lobe, mediastinal nodes, and an adrenal gland. He had negative mutation status, no targetable mutations, but his PD-L1 score was more than 50%, which qualified him to participate in a clinical trial of pembrolizumab versus chemotherapy for first-line treatment of advanced stage lung adenocarcinoma. So here's his baseline scan with the primary here, and on his PET scan, you can see that the primary, as well as a lot of lymph nodes, take up FDG. 6 months into the trial, the primary tumor site was much smaller, and his adrenal met and the mediastinal nodes had essentially resolved. But 9 months into the trial, the patient developed cough, exertional dyspnea, and oxygen desaturation with exercise. This is his CT scan at that time, and you can see that there is his right upper lobe lesion, which had shrunk considerably on therapy, But adjacent to that residual lesion, there was now infiltrate with some atelectasis and consolidation. He actually had other areas in that right lung in the lower lobe where there was this denser infiltrate with some air bronchograms. The differential diagnosis for this patient is the same as for all patients with lung or other cancers where you have infiltrates that are unexplained. This could be infection, cancer recurrence, hemorrhage, PE, or in this case, potentially immunotherapy-related pulmonary toxicity. He had a CT scan that was negative for PE, and he underwent bronchoscopy with cryobiopsy of this right lower lobe area. And that biopsy showed organizing pneumonia with negative cultures. And so the assessment was that this patient had pembrolizumab-associated organizing immune-mediated pneumonia, and that the severity of the toxicity was grade 3. And I did want to mention the ASCO Guidelines for management of immune-related adverse events, because I think this grading system is incredibly useful. It's pretty simple. It's grade 1 through 4. And I'm not going to walk through this whole thing, but there are very simple descriptions of how the grading system works. And in this case, this patient needed oxygen, supplemental oxygen. And so that put him squarely as grade 3. And because of that, the decision was made to permanently discontinue his immunotherapy. So he was started on prednisone in September 2015, again, because of the grade 3 pneumonitis, and he was tapered off steroids over the course of a couple of months. And his CT scan a couple of months after that shows that all of that infiltrate had resolved. And remarkably, this patient had no recurrence of his cancer off immunotherapy, having been treated for about 9 months. And he is still alive and doing well and cancer-free. And this was really one of the early lessons. We were so concerned about using corticosteroids and trying to avoid that because of the concern that it would interfere with the immunotherapy. But it turns out that's probably not the case. And although you shouldn't use steroids indiscriminately, when it's necessary, go ahead. The course directors wanted me to include a comment about COVID-19. I would love to forget about COVID-19, but it keeps coming at us. And to point out really that it can be very difficult to distinguish COVID-19 infection from immune-related pneumonitis in our cancer patients who are on checkpoint inhibitor therapy and get COVID. COVID patients can get diffuse ground glass infiltrates. They can get patterns that look like organizing pneumonia, and they can even get interstitial lung disease. We can't do bronchoscopy because we don't want to aerosolize virus. And often these patients are sick for a long time, and so we don't have the luxury of, well, it's an infection, let's look at it in 2 weeks, because they often stay sick. And so you will have to make an empiric assessment of whether or not those patients have just COVID pneumonia or immune-related pneumonitis. And again, these decisions can be very, very difficult. And so the takeaway points for pulmonary toxicity related to immunotherapy is that up to 4% of patients with lung cancer treated with immunotherapy develop pulmonary toxicity. This is in clinical trials, and that may actually underestimate the number of patients with lung cancer treated with immunotherapy who will develop pulmonary toxicity in general practice, because there were a lot of patients with lung cancer who were excluded from those trials who will be treated with checkpoint inhibitors now. The anti-PD-1 agents seem to have an increased likelihood of toxicity compared to the anti-PD-L1 agents. Assessment of the grade of toxicity is important and will help you guide management. And treatment of RAEs with corticosteroids does not appear to affect the cancer benefit. And so I just want to leave you with one thought. These patients are really hard to assess, and we have invested a lot in their care, and they've often invested a lot in their treatment. And so these decisions about, is this a pulmonary toxicity, are incredibly important because of the consequences of determining that that is the case and recommending discontinuation or continuation of therapy in patients for whom that therapy may be having benefit. And I'm going to stop there and I think open this to the panel.
Thank you so much, Lynn. As always, thoroughly researched and elegantly presented, as only you can do that. I want to ask Ray to jump in. Ray is a medical oncologist, again, from Memphis, and often Ray turns to us for a little bit of help here. Sometimes I think oncologists manage some of this on their own. Ray, just in general, everything you saw in this lecture, how much of it resonates? Are there areas that concern you more or less? And tell us a little bit more about this tension that occurs between patients and providers, especially when the drug is working and you kind of have to talk about stopping drug versus, or stopping drug treatment, and then maybe would you re-challenge? So if you could just give us a general overview from the oncologist perspective, but then focus on a patient and that tension.
Sure, Gerard. I will echo your comments about the comprehensiveness of Lynn's presentation. Very well researched. This is about the most comprehensive coverage of the topic I recall sitting through. Pretty impressive. All credit to you, Dr. Tanoue. Big deal. We are excited in thoracic oncology that we're now in an age of light, if you will, age of discovery, where the incredible depression of essentially the 20th century, where we had all this global pandemic of lung cancer and not a heck of a lot we could do for it, is now receding fast behind us, and the pace of discovery is breathtaking. Pardon the pun. It's incredible, and as these drugs are coming in, where they're coming in super effective because the development is driven by knowledge of cancer biology, and so they tend to work pretty well. And for those of us old enough to remember the way it was when we actually would debate whether there was any point to systemic therapy off trial for a patient with stage 4 lung cancer, we want to cling to our medicines when they work. It's really tough when you have a patient who has a horrible cancer. You walk them off the edge of the cliff, promise them treatment. The treatment has worked. Their symptoms have rapidly abated, which is the other thing that happens with these drugs. The responses are quick. Patients already begin to feel much better, and especially the tyrosine kinase inhibitors, when we do the scans within 6 weeks, you can see stuff clearing. In fact, I remember years ago when we first started out with gefitinib, before we even knew what the driver mutation was, I would have these patients who would look like they had miliary tuberculosis. And we would start them on this drug, stuff would clear up. And the first few ones we thought, well, it could have been the cancer. There's no way the cancer cleared up so fast. So these patients respond. So you can imagine the disappointment when we went through a hiatus of feeling good, and then somewhere along the line, suddenly we start this cough. The oncologist's initial response is to want to ignore it. Well, you got COPD, you got lung cancer, of course you cough, The patient's initial response is to want to, ignore it. Typically, it's the spouse that says, nah, this cough is driving me nuts. It's pretty bad. And then we find out that cancer doing better, but oh my word, scans look kind of bad. It's tough. It is probably more common, I think, as an oncologist. I see this more commonly than maybe I acknowledge. And honestly, when I was looking through Dr. Tanoue's slides a few days ago, I thought, well, these are pictures like almost all of my patients have. What is the big deal? So there's a gradation, of course. Most patients will have these changes with few symptoms, and the oncologist's response is usually to ignore them until the patient really drags their attention to it. And then we confront the idea of, oh, gee, okay, is this infection? Is this cancer getting worse? Is this, interstitial pneumonitis or some other inflammatory condition? It's a hard and I think increasingly common problem as our patients are living longer and being offered multiple different types of treatments over the course of time. Gerald, I hope that begins to address your question.
Absolutely. I have a question here, and I'm going to from Kevin. Hey, Kevin, thank you for asking a really good question. And it actually wraps into a question I'll ask both of you about your experiences with re-challenging and with steroids, and also using perhaps other agents when you have steroid refractory treatment. Look, we've all seen some of these patients, and one of the most terrifying things to me was this patient who had an outstanding response and then had this sort of ARDS, almost what we used to call Hammond-Rich, pneumonitis, and marched through steroids and went into respiratory failure and died within a month. And the steroid effect, the immunotherapy effect can last much longer, even when you withdraw the drug. Much longer, by the way, in a good way as a treatment, but also in a bad way as a side effect. But the question here is, what's your experience in steroid refractory immunotherapy pneumonitis in terms of efficacy comparing IVIG to others, mycophenolate, infliximab, et cetera? In their limited experience, efficacy seems comparable with lower infection risk, but wanted your expert opinion. Have any of you used other agents rather than steroids? And is that when you're sort of like throwing your hands up saying, I got to use something? I'll ask Ray quickly and then Lynn afterwards. Ray, could you tell me if you used?
Yeah. So Lynn's comment to begin with about our initial reluctance to expose patients on immune checkpoint inhibitors to steroids is spot on. I guilty as charged years ago. And then we learned it was okay. And then we still reluctantly use them. So sometimes I suspect that maybe we don't jump in as early as we might. So there is that. And then, of course, when you do use the steroids and they don't work, I think the immunotherapy group, I forget their name now, the organization that's trying to bring some structure to this, they actually recommend that patients with significant advanced grade pneumonitis, that you give them 2-3 days of therapy, and if they don't respond, if their symptoms don't de-escalate rapidly, to go on to second and third line immunosuppressives. So I have used infliximab more commonly. I haven't used IVIG for pneumonitis. I will confess that. I have used it for encephalopathies and things like that, and I have had good success with that. In fact, I have a patient with reversible posterior leukoencephalopathy syndrome who did, pretty well on that. But infliximab has been my experience. I've also used cyclophosphamide, as an atypical immunosuppressive. Honestly, I don't know if it's a selection issue or what, but my personal experience with them has not been as good. Maybe it's just reflective of my delayed attention or what. But I am still open to suggestions for better ways to treat steroid refractory pulmonary complications of ICIs. Lynn?
So I'm just going to throw this one thing out there. There's this small literature looking at IL-6 inhibition in lung cancer. And it's really curious because COVID comes back into this. And so IL-6 is, when IL-6 is overexpressed, that tends to be a poor prognostic factor for lung cancer. So it's being looked at as a biomarker. Tocilizumab is an IL-6 inhibitor. And in the early days of our COVID surge, we were giving everybody tocilizumab who was hypoxemic because IL-6 seems to be important in that immunologic response as well. And tocilizumab kind of fell out of favor for COVID treatment sometime last summer and fall, but it's come back. And now there's evidence that it actually is effective in patients with severe COVID respiratory disease. And there's some early literature that tocilizumab may be of benefit in mitigating immune checkpoint inhibitor related pneumonitis. This is really early, right? But I think as we understand inflammation to that level, there probably are a lot of therapies that potentially could interfere beneficially with the immunologic response. That is fundamentally what is going on with these IRAs. And so I keep trying to get away from COVID and it keeps coming back. But there's sort of an interesting body of literature. I think that's developing.
I'll just throw in my 2 cents. Look, steroids work, first of all, recognition is important, and discontinuing the drug is very important. And so the patients I've seen do poorly have been left out there for far too long before the drug's been discontinued. The second is I go to steroids very quickly. I think, there are these tapering regimens, and I can usually get them down off of steroids very quickly, at least down to 10 milligrams. And if I'm going to re-challenge a patient, there is one study that suggests that about 10 milligrams, it's okay. If you use high-dose steroids and re-challenge, you don't get the same immunotherapy effect. So 10 milligrams is probably, if I need to re-challenge and use steroids, that's where I'd go. Another question that's come up, and I'm going to take a crack at the answer and then ask just a yes, no from the crowd, is, I feel it's always a diagnosis of exclusion with bronchoscopy, and it's usually non-contributory except to exclude infection. Are there other tools in the toolbox? So the first thing I would say is I'm doing less bronchoscopy for this disease, and I love bronchoscopy, right? Lynn and I love to do bronchoscopy. And I think the two things that you look for in bronchoscopy are infection, but remember, as Lynn pointed out, these are not generally immunosuppressing drugs. So infection, if they don't have the fever and other things that suggest infection, the only other thing I'd look for in bronchoscopy is lymphangitic carcinomatosis. Generally, that's seen with bilateral pleural effusions. And now that we do CAT scans so much, it might not be seen with that, but you see this sort of lacy interstitial and nodular pattern, and that's the two areas. The other things I want you to continue to, so I don't use bronchoscopy that much unless I think one of those other things is there. I would say, thromboembolic disease, we underestimate thromboembolic disease. So think about that in all of this. And then exacerbation of underlying disease like COPD. If you have the characteristic time frame, radiographic changes and drug, then I think you should probably empirically treat in conjunction with your tumor board and your medical oncologist. So the other question that came out of it, and I would ask both our panelists is, and this is from two different people, is are there any biomarkers that might be useful in suggesting pneumonitis, or any blood tests that might be useful? So do you have any advice for our panelists on that?
Boy, if I had an answer, I would be a rich man already by now. I know that there is a ton of effort going on to really answer that question. In fact, the NIH is extremely, extremely interested in not only biomarkers of immune response, but also biomarkers of immune toxicity. In the lung cancer trials that we're designing through SWOG and other research bases in the National Clinical Trials Network, one of the issues that we are constantly pushed to address is biomarkers, the biomarker question. In this case, when we're dealing with clinical trials of immune checkpoint inhibitors, biomarkers of toxicity. So there's a lot of effort to uncover. Are there going to be biomarkers? Yes, I'm pretty sure. Are there any that we rely on? Not that I'm aware of. I don't know, Lynn, if you are.
So I'll go back to the TOSI story. You can get IL-6 levels commercially. It's easy. And so that if you believe that elevated IL-6, like we see in COVID, right, is a biomarker that maybe for that patient, I should use an IL-6 inhibitor. But that's not been proven. But I think we're this close to that.
Have you checked that in any of have you checked it in any of your pneumonitis patients, just parenthetically?
No, this is actually, I'm going to give credit to the directors of this webinar that they kind of brought this up. And so I sort of have learned a lot about IL-6.
Well, we ought to start checking it, Lynn.
Last few days, so I've learned something myself, but we were routinely checking IL-6 for COVID to decide who to give toci to. And so I know it's really easy to do. And Gerard's writing this down because he's going to do a study now.
We have a few minutes left. I wanted to talk about something that came to mind that I've seen even in this past week, for which I do think bronchoscopy is useful. We had a patient who looked like they had pneumonitis and lung cancer, and a PET was performed for the lung cancer when the pneumonitis was noticed, and they did have mediastinal adenopathy at very hot on PET, almost like that PET that you showed in the beginning of your case, Lynn. And this is now maybe the fourth or fifth patient that I've done EBUS on and found granulomatous inflammation in the lymph nodes. I just want to alert everyone that is something now that is in the literature. It's an important immunotherapy-related toxicity, and I don't want you to think that all it means is progression of their cancer. That is one time I think it's reasonable to do bronchoscopy and EBUS, and I had a patient this past week who was responding with immunotherapy, got a follow-up PET scan for one reason or another. The tumor was shrinking away. The mediastinal adenopathy was hot on PET. I was asked to look for progression, and now I'm almost starting to think, no, this is immunotherapy-induced lymphadenitis with granulomatous inflammation. Have you seen it, my panelists? Yes, no, and have you done a bronchoscopy for that and found it?
I have not seen that for this particular situation, but we have all seen patients who are being treated for cancer. Germ cell tumors in the mediastinum, where it looks like there's recurrence and they have granulomatous inflammation. So I think this is part of the presentation of antigens of the immune system. And I absolutely agree that we still need to do bronchoscopy because we shouldn't make assumptions about something as important as stopping therapy or presuming recurrence without proving it.
Yeah, I completely agree. As I think oncologists are often chastised for being so quick to ask for another biopsy, but it is for reasons like this. When monumental decisions hinge on, radiologic abnormalities, my insistence almost always is to prove, to verify. We don't even trust. We certainly want to verify. And that also leads a little bit real quickly into the comment Dr. Tanoue made about pseudoprogression. We went through a cycle where thoracic oncologists were beginning to doubt if there was such a real thing as pseudoprogression in lung cancer. It was clearly well established in melanoma. I never had any doubts because I felt I saw it in my patients. Now that neoadjuvant immunotherapy trials have been done, where patients get their immunotherapy, then go on to surgery, clearly pseudoprogression exists in lung cancer. I don't think there's any doubt to that anymore.
Well, great. We are getting to the end of our hour. I always knew that even given a half an hour, we could chat for another 20 or 30 minutes. So I really want to thank our panelists, Dr. Raymond Osaro-Giaban and Dr. Lynn Tanoue for a wonderful chat where I always seem to learn something. I want to thank AstraZeneca for supporting this and CHEST, and particularly Lily Rodriguez, who's our staff at CHEST, for helping us through this webinar. I'd remind our panelists, I remind our guests on this webinar that the pulmonologist continues to play an important role, from diagnosis to staging to providing tissue for biomarker assessment and to managing our patients after they receive treatment. and to stay involved in cancer care. So that's for all our pulmonologists out there. And I would thank everyone and have a great evening and stay safe, folks.
Thank you all.